So one thing, Jose reminded me that there have been some questions about whether or not there were some seminal articles on our meeting website. We pulled together a bibliography. Each of the speakers sent up to 3 and sometimes 4 publications, and they've been organized according to the lecture series, so you can really dive into whichever area you have a question. You should have a copy of the references in your folders, and if you want to go on the website, then you can click on the publication directly there. So I'm really happy to welcome back Jose Escarce, who's going to move us into talking about measuring organizational factors. Jose.
Good morning again. And I realized after I had titled this talk that maybe it's a little misleading. I'm not going to talk about how to do the measurement or anything like that. I'm not an expert in that area, certainly not the types of stuff that we heard in the last 2 talks, which I thought were great, but rather about characteristics that people have measured and that have attempted to measure and that might matter in the things that we're interested in. So the goal for today, again, is sort of to begin by just giving you kind of the obvious information on why health system characteristics might be important, and we're still kind of in this framework of the vertically integrated health systems that I spoke around earlier. Put up a conceptual framework just to guide that we're using to guide our data collection at RAND. Very quickly, some findings from the literature, a summary on this issue, and then I'll talk in a little bit more depth about what we are doing or have been doing at RAND, and then I'll summarize. So we're back to vertical integration of hospitals and doctors. And possibly other providers, of course. That definition wasn't meant to be exclusive. And the reason that these characteristics are important is because, or that vertical integration is important, as I said before, is because it's presumed to affect cost and quality. But beyond this constant of vertical integration per se, which is sort of the common denominator in the organization that we are talking about, the integration arrangements and the characteristics of the systems that result vary enormously. And I'll just give you a little glimpse of that a little bit later. I'm sure you know that already. And it's believed that these presumably also influence the care that patients receive, costs, and so forth. And so that's why this is important. This is akin to the conceptual that Dr. Breslau showed at the beginning, but basically this is just to give you a reference for the types of measurements that people tend to undertake and that we are undertaking in the RAND context. So you have this big market environment outside. Within that, you have the vertically integrated things, hospitals and doctors, and then, of course, practice sites. And then individual physicians should be in that loop as well. And then that all impacts the patient, who is at the center of all of this. And in theory, there are some outcomes that we really care about, and they're always all the way over on the right-hand side, and those are the quality of care, which affect how patients do, the efficiency of the system, and then in this particular paper, they refer to patient-centered outcomes. Well, quality are sort of problem measures, and patient-centered outcomes are outcomes, mortality, things like that. So quickly, some findings from the literature. Most studies, the truth is, they are limited to comparing providers that are in vertically integrated systems and those that are not. And I'm referring to studies that are interested in this question of how integration is affecting care. So at least in the health services, health economics literature, when people do studies to look at the impact of this on quality of care or on cost, they're typically comparing integrated providers in integrated systems and those. There are certainly some studies that consider the characteristics of the healthcare systems, although there are few studies and there are few characteristics. One that is typically or more often studied than others is the degree to which a system is centralized. And by the way, one of the papers that I sent Dr. Breslau is a review of the literature on this question. The second thing to know is that most of the evidence is what people who rate the evidence that is available in the literature would rate as low quality. And why is that? Well, most of the studies are cross-sectional. Most of the studies, as a result, report associations. They tend to admit this. There's very little pretense of sort of identifying or estimating causal effects. And another dimension of this is they really don't address selection of providers into health systems. That could be important because it's not random who is in a health system. And also the endogeneity even of these characteristics. And by that I mean systems may actually choose to be in certain ways for particular reasons. Those characteristics aren't randomized to systems either. And so the studies don't address that question. And so if you're strict about the quality of evidence, most of these studies have low quality evidence. So some of the findings are this, quality of care, and these are tend to be both process measures, although hospital outcomes are also included. And they focus on disease-specific quality measures, things like prostate cancer, colon cancer, diabetes. They focus on cancer screening. Several studies focus on hospital outcomes. These include mortality, complications, readmissions. And I would say the results are mixed. Also true that more studies find better quality in health systems than outside. Remember what I said about most of the literature comparing systems and providers that are not in systems. So this is sort of now, probably the biggest share of all the studies show no difference. So it's important to know that. But among the studies that show a difference, many more of them, or substantially more of them, show that process measures in particular are better in health systems than they are outside. There's a flip side to this. We talked about this in my first 10 minutes, and that's the impact. So most studies focus on prices, on use, or on expenditures, which is sort of prices times use. And and most examine hospital care, although there are some that look at physician care or physician services as well. Here, the evidence is much more convincing, I suppose, or a much higher proportion of the evidence indicates that prices and costs are higher in health systems. So this idea health systems change the market, obviously. They concentrate it more. It gives them more bargaining power with providers. Therefore, they extract higher prices. And in some cases, they're able to do things that generate revenues. It seems to be real. So this is a fairly uniform finding in the literature. Here's a couple of things from the California Healthcare Foundation. They had a blog a couple of months ago. The title is Vertical Integration Bad for Healthcare Consumers? And this was actually a summary of testimony before the Senate Judiciary Committee, which brought in a few experts on this issue. And they were pretty clear that, the issue of prices and costs was an important one, and that the findings about quality were kind of equivocal because they were not really consistent. The measures were different in most studies. How the samples were identified were different, and so, but the evidence regarding cost and prices is pretty clear. And then there's another publication from the California Healthcare Foundation. And as you can see, the title of that is very provocative, right? The sky's the limit. And they're talking about prices when they're talking about the sky's the limit. So in the RAND Center of Excellence on Comparative Health System Performance, our goals are to try to enumerate and characterize health systems in the United States. We try to characterize system-affiliated and unaffiliated physician organizations. Physician organizations are mainly medical groups, and the Medicare beneficiaries that they serve. So we're largely focused on the Medicare population. We try to assess, our second objective is to assess the performance of these systems, and then to examine the association, and I'm back to that word, between health system characteristics and performance. There we go. So we have a bunch of data sources. It's taken a long time to do this work. And we have a bunch of data sources from Medicare. They include the provider practice and specialty, which we called MD Pass, the provider enrollment and ownership system, which is called PICOS, and it's really a very valuable data set that I had never worked with before. And it's difficult to work with, but it's been extremely valuable in trying to stitch together medical groups and hospitals and systems and their owners and things like that. Much more conventionally, people use, and we're using, Medicare enrollment and claims data, the Medicare provider of services file, hospital and physician compare. Another database that I had never used but has proved to be extremely valuable is IRS Form 990, which is actually public use because these are the forms, or they're public, because these are the forms, this is sort of the equivalent of tax returns for nonprofits. And so they need to do this. And so it has contributed to our ability to stitch together organizations and to create health systems. We use the AHA annual survey of hospitals, and then a bunch of other things here and there to plug in holes and to try to add additional characteristics. It's been a lot of work. We have unbelievable programmers at RAND, actually, and without them, this would have been impossible. But even for them, it's been a very difficult task. And so what we do is we try to identify physician organizations, POs, over on the left-hand side. And then we attribute Medicare beneficiaries to these physician organizations, and this is fee-for-service or traditional Medicare we're talking about. And we have a certain algorithms that we use to do that. And then we take these POs, and we also take hospitals, and we map them to systems. And it says PICOS there, but actually it omits the fact that the IRS 990 forms are a prominent part of that, as well as additional databases and additional information that we have brought to bear on this. And then we try to describe those characteristics, the beneficiary served, and performance on a number of measures that I'm going to enumerate or list in a bit. So these are the characteristics that we are trying to measure. Location, where does the system generally operate? And we use the hospital referral regions as the basis for placing systems, and there's like 310 or so in the United States. How many doctors they have and detailed specialty composition, how many advanced practice nurses and physician assistants they have, how many practice sites they have, and what is their locations. And we classify locations into urban, suburban, small towns, and rural. How many hospitals they have, and of course, measuring hospital characteristics is pretty straightforward using the AHA annual survey. The number of Medicare beneficiaries and sort of who they are in terms of demographics and things like that. We've developed measures of competition and market share. Know the ownership type, at least for-profit, not-for-profit, and then of course there's some safety net systems that are owned or where the central hospital is like a county or a city hospital. We know whether the system is academic or not. We know a little bit about HMO adoption and use. These data are partial. And we know about participation in alternative payment models like ACOs and so forth. So it's a bunch of stuff that we tried to bring together for the health system. And it's a lot, but in a bit I'll talk about whether it's enough. And so if you go back to the framework I presented, I put a red circle around the things that we have touched on, and in a sense we've touched on every one of these things. For doctors, we know their specialty, we know a couple of other things. We know where the practice sites are located, et cetera, all the things that I talked about. For market environment, we know the market share, we know the degree of competition in both the doctor services market and the hospital market. So just a couple of quick findings. The first thing is we actually found 1,397 systems. And I talked about 477 the last time, but that's because one of the things we found that ARC doesn't talk about in the generation of its compendium, and we're pretty sure we're right, or at least close to right, is that the country is just awash in these very small healthcare systems. And they do meet this definition of hospitals and doctors groups integrated. So you'll go to a relatively small town in the Midwest in Missouri, for example. It's a town of 40,000 people, and there's like a hospital there. It's an important hospital to that community, provides care, employs a lot of people, and it's vertically integrated with the doctors group of 30 doctors. And we thought that was really interesting because nobody has talked about that. So 920, in fact, of the systems that we found are these small systems. So we think that's kind of pretty interesting. And then if you go from that line down 50 and above, then you see the others that I described. That adds up to 477 there. And you can see I put in, because we're at the NCI, the percentage of these systems that have an oncologist. And you can see that the bigger they are, obviously the more likely they are to have an oncologist. These small systems tend not to have an oncologist. I also wanted to show you, okay, so what physician organizations join systems? And the thing, there's a mistake on this slide. I'll point it out in a second. Solo docs, there's still about 80,000 of them in the U.S., and we verified that number more or less, benchmarked it with American Medical Association survey. So about 15% of doctors in the U.S., amazingly enough, are still in solo practice. And they're never in systems. In fact, those 349, that's probably some sort of data error or something like that, because they're probably never in systems. But it's a tiny percentage. And then the bigger the practice gets, the more likely the practice or the group is to be in a medical, in an integrated health system. At the bottom, the number of systems is 686. Groups. There are 686 groups in the U.S. with more than 100 doctors. Not all of them. So that second 686 is a mistake. My apologies. But the percentage is correct. So once you get to have over 100 doctors, 61% of the time you're going to be in one of these integrated healthcare systems. So we also measured system performance, and we have a bunch of clinical performance measures. They tend to be HEDIS measures, so cancer screening, chronic disease management, high-risk medications, whether you're on them. We have measures of this, this very popular concept now of low-value care. We have some hospital-based measures, and then we have cost of care measures that we haven't finished, but we've almost finished developing. And I do have some preliminary results. So these is sort of how these health systems perform. So disease-modifying agents for RA. I mean, all of these, the higher you are, the better. For the one at the top, that's why it has a star. That's readmissions, and the lower you are, presumably the better. But you can see that the systems are variable, right? So monitoring the kidneys in diabetics, that's pretty good, over 90%. Breast cancer screening is only at the 70% range. These are HEDIS measures from claims data, so there's reason to be skeptical that they're right on target, but certainly they show something. Osteoporosis management, well, pretty low. So there's variation in how systems perform. And there's also variation across systems in their performance. So across the x-axis here, you have the so-called coefficient of variation, which is a measure of the variability in performance. It's sort of the standard deviation divided by the mean. And then you can see that it plots versus performance level. So for the things where the performance is highest, the coefficient of variation is lowest, and you might say, well, that makes perfect sense if everybody's performing really high. To perform high, everybody has to be performing high, so there wouldn't be a lot of variation. But in any case, there's a lot of room for improvement in both elevating performance and then also in reducing variation, because experts on this think that variation in performance is an indication of inefficiency and not managing the health care that you provide very well and so forth. But I think the key question is whether the characteristics that we're measuring, which are all structural in a sense, irrespective of which dimension of the conceptual framework they pertain to, whether they are enough, and whether the most important factors affecting performance perhaps simply can't be captured in secondary data. And I think this, in a sense, is quite relevant to the two talks that preceded this one. And so if that's the case, then of course the cliche is obvious, because this is where we're looking, and that's where the answer is over on the other side. And so we also developed a mixed methods component to the study, or a qualitative component, where we sampled 24 health systems, and also for each one their POs. And we conducted virtual site visits with interviews with executives at the health system level, and also at the level of the physician organization that we had chosen. And we included history, the market context and the strategies, governance and management, leadership and culture, where decision-making was, Was there a commitment to redesigning care? Did they even know what that meant? Quality improvement and efforts to move evidence to practice, talked about in the previous talks. How did they pay people at different levels? Did they assume financial risk, and who within the organization assumed it? How did they measure performance, et cetera? And then we had additional questions in a survey after these interviews. And there's enormous variation in these things. It isn't just in these structural measures that you can measure with secondary data, as you might guess. So in organization and governance, and the variation I should add is both across systems and within systems. So most systems have core components, they're like really in there with you, and then some peripheral components, which they kind of affiliated with probably for the purposes of gaining additional market power. They don't control them very much. It's a little loose, you know, but they go to and say, or to the with this whole set of groups, and that's important. A whole ton of different relationships between systems and doctors. We're good. They have different strategies to address competition. I was kind of talking about this. Do you acquire and merge, or do you simply affiliate with them? And that's kind of what creates these peripheral components. What they use to influence performance varies between the core and peripheral components. With the peripheral components, it's a very, very light touch in many cases. And then, of course, the locus of decision making. So there's so much variation, and there's many more. So much variation within systems and across systems that you can see how difficult the problem this is. Not to mention the fact that, you know, as I said before, many of these things are kind of chosen deliberately with a purpose in mind, or at least with an intuition about what might work. So just to summarize, vertical integration per se is associated with higher prices and costs, and several studies suggest that it may be associated with higher, at least process quality as well. But an important caveat is that most of the studies provide quality evidence. The characteristics of these systems vary enormously, but there is not a whole lot of research on whether and how these characteristics matter. It's possible to measure structural characteristics using secondary data sources, or at least we think so. When we started the project, we really weren't sure. Now we think so. We think we're kind of close to the truth. But there are two huge challenges to research on the relationship between system characteristics and performance. The first is the difficulty of measuring attributes that may be as or more important than structural ones. Those are the ones we're picking up with our qualitative component of our work. And then secondly, and this is very difficult, I think, moving beyond associations to identify and estimate causal effects, because this requires either natural experiments or, of course, implementation work that was talked about before. And natural experiments, at least, are hard to come by, and my sense is that implementation work is also really hard to do. Thank you.
Hi, my name is Rendell from University of Pennsylvania. Thank you for the summary and highlighting how hard this work is. I think I have a general question that's probably really hard to answer, but with all the variation, how much should we be pushing towards sort of a standardization of how we measure these things? So then we can sort of have an apples to apples measurement to then do causal associations. Is that even possible? Sort of what thoughts on that? Or can we sort of have these mixed methods interviews with some structural secondary data sources and sort of get at a as comparable as possible when we're comparing these systems? Sort of what is a balance between those two things?
So I have to say that, to be honest, I don't know the answer to the question. I mean, I would say that, I mean, I don't do qualitative work, and so we have experts on our team who find that's the qualitative component, and I think they would say that it's possible to, as long as you make certain decisions about the framework you're using, it's possible to do this in a uniform, standardized way, the measurement that is, that would enable you to compare organizations in terms of their attributes and maybe try to figure out how the attributes make a difference. I think with the structural measures from secondary data, that's much easier. That's kind of what I do, I guess. And so there, I think standardizing the measures is straightforward. If your data are cooperative, then you can, or collaborative, you can do it. Yeah. And I'm sorry, I don't have a better answer.
Shoot, because I'm asking a question further in the weeds than what Kate just asked. My name's Deborah Ritzwaller, economist from Kaiser Permanente, and so given my background in Kaiser Permanente, and I was really glad to begin working there several decades ago because of structure that I saw, especially around the physician compensation, which is predominantly 95% salary-based. So the volume, the incentive for volume is there. So I'm not quite clear. According to the definitions you originally put up, I don't think Kaiser Permanente as an entity fits either a horizontal or a purely vertical system integration. It's more of a healthcare kind of a piece.
Well, but it's vertically integrated. The doctors and the hospitals and the health plan, of course,
so I'm in
vertically
Colorado.
integrated.
We don't own the hospitals, so it can be a bit of a mix.
Okay,
it
so
can be a bit of a mix.
Okay,
So purely
right.
definitional, and we have some variation. So
Sure.
we have even, I can think of a consortium I won't name that even within the Kaisers, there's a lot of variation that one could address. But back to Kate's question, and reflecting on both, the market power, the vertical, horizontal, and the unequivocal evidence that you have presented and published around prices and integration in health system from the fee-for-service market, but I'm not clear that that holds in the non-fee-for-service based systems like a Kaiser or a Geisinger or something like that. So thinking about how to assess how those incentives matter, there's sort of a structural order, even thinking of the non-qualitative pieces, where one should think about, when thinking about modeling the variation in both quality and cost, if you're comparing outcomes for, say, a system like a Kaiser and a system like Penn. So just hoping that you'll help us with our project is where I'm going with this. But are there particular structural sort of models that one could think about to address whether it's at the beginning at the physician level, so assuming away that, I'm an economist, assuming away the patient at this point, the fee-for-service versus salary, and then the organizational pieces? So I know I just did a whole jumble of questions.
I'm an economist too, so I'm happy to assume away complexity whenever you want. And also, by the way, I was a medical student at Penn. I was a doctoral student at Penn, and I was on faculty at Penn. So if you want me to come to Philadelphia to visit you, I'm happy to come. So anyway, I think the key thing here on this issue of compensation and is to separate clearly what level you're talking about. Who's getting compensated how? And so a colleague of mine a long time ago at Penn who wrote a lot about managed care organizations when they were starting out and really growing fast in the late 80s. His name was Alan Hillman, and unfortunately he died very young. But he wrote what I think is a really good paper, and I always share with my students. And it was called something like 2-tiered and 3-tiered healthcare organizations or something like that. But the point, which is, by the way, should be obvious, but it's amazing how often it isn't, is that, let's say organization. There's the physician organization. How are they paid? And then how does that physician organization choose to pay the doctors that work for it? And of course, they might pay the specialist primary care doctors differently, et cetera. But what's clear is that whatever incentives impinge on the organization, they need to transmit or transfer over to the doctors in some way so that the incentives will be, quote, aligned. That can be done through financial incentives, or it could be done by imposing all sorts of productivity requirements, monitoring of this, all sorts of rules. Alan used to say, financial incentives and rules. And so that combination of financial incentives and rules is really kind of probably the way to look at this. But never forgetting that there could be 2 tiers or 3 tiers. in these organizations. In the case of a health system, it's often 3 tiers because it's the system, and then there's the physician organizations within the system, because some systems have more than one, and then they, of course, have to pay their doctors. And that, so you can see a set of incentives at the system level, depending on how they bargain for prices, whether getting capitation payments or a global payment or fee for service, and then how do they move that down to their doctors.
Thank you very much. That was great.